As Stephanie told, I was very surprised when I realized that I had to talk about adults with CGG. Because as you see, as you know, I am a pediatrician, but those of you who deal with metabolic disease patients know that many of the times we have to care also about adults. Well, there are. I realized that although there is an increasing number of patients that are diagnosed when they are already adults, this group of patients is still not so numerous as those who we have been following since infancy, and that now, more than 20 years after the first description by Jack Jagan, they grew, and they are some are old. We have patients also in their 40s. So it's true. We follow also adults with CDGs, and if I give a look to the recent survey made on the Italian patients made with Rita Barone, that you know well, we realized that among 37 patients, more than half were adults with an age range between 19 years and 68 years. This one was an old patient, not from Catania, but from another Italian town. And all of the other patients with different forms, with non-PMM2 CDG, are all younger because they have generally a severe form, although we have an adolescent one with ALG1. Well, my job is easier today because many of the previous speakers treated many with a specific ability the fields I am going to treat, and I won't take much time if not for underline some aspects. We all know which is the clinical picture in infancy that can be very life-threatening. We can have liver insufficiency, we can have serious problems in the first years. But when PMM2 patients grow, they may have a chronic disorder, which is different from, for example, lysosomal disorder, which have a progressive deterioration. They get worse and worse with time. They have a more stable clinical picture, and the major concerns are, as you already heard, the coagulation problems, the skeletal problems, the eyes, and the nervous system involvement. I am not lucky because Dr. Common is not here, and he did not treat the skeletal problems. I would like only to remember you that because of kyphoscoliosis and chest deformities, the respiration can be involved with time, and because all the structures can involve the lung expansion. So as in other accumulation disorders, we can have in our patient problems with a normal respiration. We have found good results with what we call respiratory physiotherapy, teaching to the patient to breathe in the right way and finding some maneuvers that can help in expelling the mucus, what can interfere with oxygen exchange in the blood. But another problem is the osteoporosis, as you heard. Osteoporosis can be more evident, is evident also in infancy, but can be more evident with time. And many years ago, Rita and I made this assessment of skeletal parameters in our patient, in our old patients with CDGs, and found a significant presence of osteoporosis. To be more clear, our many functions of our body are the result of an equilibrium between, in the case of the skeletal system, bones have a life. I mean, they are not statically formed, but there is an equilibrium between bone formation and bone resorption. And in CDGs, there must be prevalence of the osteoclasts activity, which are those cells that erode the bones, while the osteoblast doesn't work well as we would like. And many solutions can be tried in our patients. For example, biphosphonates can be used because of their modulation on the osteoblast-osteoclast relationship. Or, for example, the French group suggested the calcium supplementation for these patients. Nevertheless, there is no clear evidence of the efficacy of any other of any of these treatment. And this open also the way to the there is a mistake in the table, is hypogonadotropic hypogonadism. As you heard before, for example, estrogen supplementation can be a good way to restore the bone density. But we must face with the other problem, because estrogens have been involved in increased risk of deep vein thrombosis. So what to do in our patient? You just heard about the delicate equilibrium that also in the coagulation cascade does exist. That is an equilibrium between thrombotic and anticoagulant factors. So have we the risk of bleeding, have been more the risk of thrombosis? We heard it should be so. And there was an initial theory that we could treat chronically our patient with aspirin because of its anticoagulant activity. We do not think this is right at the moment. It could be more safe to monitor with time the coagulation parameters in our patients, mainly during stressing situation. As you heard, during in prevision of a surgical event, we should monitor the coagulation factor and decide what to do. Another concern in patients with who grow is the appearance of retinitis pigmentosa. The involvement of the eyes often can happen later in the life, can be early, but sometimes can happen in a few months or years. So the annual monitoring of the eye by ERG and by fundoscopic examination should be made regularly. What can we do if we detect an eye problem? The reason is that we should try to improve the stimulation of these children. When I make a new diagnosis, what I say to parents is try to stimulate as much as you can. Don't give up any moment of your day, because with time you will you will find your results. And we all know that many times they reach the ambulation or talk very late in their life, late when we compare to peers. So we are lucky today that we live in a so-called technological era. So we have many technological means to stimulate these children since infancy. Why I do talk about this now that I have to talk with about adults? Because I think that it's really so. The more we do during the first years of life, the best the patient will deal with this environment. And also in terms of socialization with other people. We all know how cheerful and happy and friendly are our patients with CDG. And so it's very important to help them in the daily life to grow without problems in terms of social interaction. I also look at in our series to the neurological problems in the adults one. As you probably saw in the report, we distinguished two groups of patients because Rita observed that milder phenotypes linked to the so-called L32R mutation. And what I want to tell about this label is that although ataxia is, of course, one of the most important problems also in the adult life, stroke-like episodes are not so frequent. They are present in almost half of our patients in adult age, as well as epilepsy. But we must be aware of the possible onset of the peripheral neuropathy. So monitoring the patient in the follow-up control is very important, although I agree that both MRI and nerve conduction velocity could be made just if we have clinical signs that suggest us to do it on an early, but it's not necessary every year. Okay, I will skip on this aspect because Rita already told you about, and I will take a few minutes to talk about some practical problems. We follow these patients since infancy, and they grow up, they become adult. So we have some problems in assisting them in pediatrics ward. This is because now we have so many laws that indicate us which is appropriate or non-appropriate. So when I admit a patient who is older than 16, I have a problem with administration. and this is the daily life. But I realized that we do this. We do for other metabolic disorders. We do, for example, for Rett syndrome patients. So we don't care about. For us, they are our kids, no matter which is the age. But we should transfer them to the adult medicine for many reasons, not only for bureaucratic reasons. And this is a very hard moment for the family and for the patient. Moreover, we have to think that we face with adolescents. Adolescents, no matter which is the chronic disease they have to cope with the physical change, the emotional feeling of being different from the other peers. And this can determine both low compliance to our follow-up, but also isolation and depression. So this is common to many other chronic metabolic disease, which is the theater of this. On one hand, the pediatrician, like we are, like I am, do not feel confident to leave our patient to another doctor. Even we postpone the problem. We do not think until someone arises the problem. And the family is anxious about living a normal environment where they feel like home. They have been with us for several years. And also we have to identify a doctor who is able to understand which is the disease. I took this cartoon substituting the name of the disease with PMM2, but it can be any other CDG form, where the new doctor says to the patient, you have PM2 CDG, medicine knows very little about, even we do not know how to pronounce it. So this is just a cartoon, but it's real. Many times adult doctors do not know our diseases, do not know CDGs. Although they can be specialists and they can give us a skillful assistance to our patient, for example, for what concern skeletal problems, endocrinological problems, and so on. So what we should do? We must raise interest. We must involve the new doctor. Don't wait for the last moment. Don't drop the patient to the new doctor without information. Maybe that we can organize some meeting, let them understand that they can have a patient and in an adult patient who goes to their office and they do not understand that the patient can have CDG. So we should increase their curiosity about. This is a study that's been made in 2009. It was a questionnaire given to the families about their concerns in the transition from one clinic to the other, and of course the most frequent answer was that they felt the new doctor did not have experience in that field. So we should start to think about preparing this kind of transfer, talking in advance with our families, because we know how hard it is for them to change doctor, and we should also. It's the end. Oh no. We should also consider a transitional period in our clinic involving the new doctor and sharing with him all information during the follow-up visit, and if possible follow the patient when he starts to be followed in the adult clinic. In other words, there must be a team that takes care both of our children, adolescents and adults and their families, and I think that we could start thinking that also this association can help giving material, giving informed posters like Vanessa taught this time, and make all working together to give to our patients the best that we can. Thank you.